Hi, everybody. This is part 3 of week 2 lecture series, I guess you can call it now. And we'll be talking about oxygenation, specifically with respect to um, low flow and high flow devices, non-invasive ventilation, and some suctioning. It's very important to understand how oxygen works in the critical care transport scene specifically, so that you understand the importance of that and how it relates to what we're going to talk about with mechanical ventilation. Oxygenation, as you know, is very important, especially in people who we are transporting who have airway difficulties, often because these patients don't have much reserve when it comes to O2. Um, Lots of things within the transport environment can affect a patient's ability to oxygenate. So any kind of movement, position changes, altitude shifts for flight, any delays during patient packaging or handoff, those can all push a patient into respiratory failure for hypoxemia. Oxygenation strategies have to match the disease process that the patients have, their work of breathing, and the expected, course, overall that you would want the patient to have during the trip. So, high flow nasal cannula, non-invasive ventilation, those two modalities can sometimes prevent intubation, but they also fail. And then suctioning, we'll get into a little bit. That's still a core skill that everybody needs to know, and that alone can make or break any oxygenation strategy. Learning objectives for this, by the end, you should be able to do 4 things. You should be able to explain the main determinants of oxygenation and how transport stresses those factors. You should be able to describe when and how to use high flow nasal cannula, non-invasive ventilation, and really any of the other oxygen devices during transport. You should be able to differentiate between CPAP and BiPAP and match each of those to the clinical scenario. And then finally, you should be able to describe safe suction principles for all patient populations, including adults, pediatrics, and neonates. All right, so section 1 for oxygenation, we'll start by kind of zooming out and looking at oxygenation as a system. So instead of asking, what liter flow should I use for a nasal cannula or something like that, I want you to think along the lines of, where along the oxygen pathway is this patient failing, and how will transport make that worse, and what can I do to make it better for the patient? Key determinants of oxygenation, there are several. So these pieces are key in working together to determine how a patient is oxygenating. So we need adequate FiO2, so that's the fraction of inspired oxygen or the percentage of the oxygen being delivered. We need recruited open alveoli to be able to accept and help transport that oxygen into the bloodstream. We need good ventilation perfusion matching, so that's VQ matching, V for ventilation, Q for perfusion, so that blood actually reaches the ventilated alveoli to be able to carry it to the rest of the body. And we need adequate hemoglobin and cardiac output to be able to carry and deliver that oxygen to the tissues. In transport, a number of things can, erode a patient's oxygen reserve. Atelectasis, pulmonary edema, pneumonia, aspiration risk, ARDS, those can all worsen with position changes, loss of PEEP, altitude changes, things of that nature. As far as the circuit and the the equipment and the tubing go. Tube migration can have a big impact. Any time you have a circuit disconnection or a leak, any mucus plugging within the airways, retained secretions within the airways, those can all suddenly increase resistance or block airflow, and really decrease the patient's PaO2, or um, partial pressure of arterial oxygen, which is a value on the arterial blood gas result. Other things like fever, agitation, high work of breathing, those can increase oxygen demand. And for air transports, lower ambient pressure at altitude can worsen the marginal gas exchange within the lungs. So oftentimes we need higher FiO2s when we are higher in the air to help to overcome and compensate for the altitude change. And that has to do with the alveolar oxygen equation, the P big AO2 equation, but I will spare you guys that. um, and so your job is to anticipate these threats while you're en route, instead of waiting for their sat to tank and then they crash and then you have to fix. And being proactive with oxygen, with proper oxygen delivery based on FiO2 and the oxygen device, can help to save you a lot of trouble should things go south. So when we look at what oxygen device to put on a patient, you always want to have a strategy. Your first priority should be to correct any reversible cause. So reversible causes include an airway obstruction, so removing the obstruction, any kind of disconnection, make sure all the connections are tight, equipment failure, poor positioning, secretions, if they have secretions, suction those out. Second, pick the lowest level of support that reliably meets the oxygenation and the work of breathing goals. We don't want to escalate support when we don't have to. Oxygen is a drug, and it has adverse effects, as all drugs do. And we want to allow the patient to do as much of the um, breathing process as they can comfortably, so that it's easier to wean them off when they improve. Third, try to avoid frequent or repeated de-recruitment. So recruitment has to do with PEEP being positive end expiratory pressure. Whenever you are bagging a patient with a BVM, you should have a PEEP valve on top, and that should be set to somewhere between 5 and 10, depending on disease process. And we want to make sure that we keep that PEEP delivery consistent, because if anytime we back off on PEEP or decrease PEEP or remove PEEP, that creates de-recruitment within the alveoli, and that can impede gas exchange and oxygenation. Finally, you want to monitor trends, not just single numbers, but watch for the work of breathing, watch the SpO2 as it migrates up and down, watch the end-tidal CO2 as it migrates up and down or stays down. Frequently check their breath sounds to make sure there's no change within their internal process. And then also, importantly, their mental status over time. Level of consciousness is imperative with regards to oxygenation. Anybody who is hypoxemic or has low blood oxygen, they will begin to get disoriented, confused, eventually lethargic, and if it gets too bad, somnolent, and they'll hypoventilate and end up crashing. So for the next few slides, I've integrated some of the slides that I teach for RCP 100 in the oxygen section. So the difference between a low flow and a high flow device is something that most everyone other than RTs and hopefully now EMTs understand. I've had to do this teaching for nurses, even for residents. They just don't understand the concept. So when we talk about oxygen therapy, the devices that we have at our disposal are largely divided into low flow and high flow devices. So what that means is um, everybody has like an inspiratory capacity or an amount of flow that they use with each breath. All right. Um, that amount is typically looked at over the course of 1 minute. So when we talk about minute ventilation, tidal volume times frequency, it's a similar kind of concept. But in terms of flow, so that's the amount and the speed at which the air that I inhale goes in. The device that we use for supplemental oxygen, if that device provides a flow rate over the course of a minute that is less than what I would or what the patient would inspire on their own, that is the definition of a low flow device. So nasal cannula, simple mask, partial rebreather, non-rebreather, face tents, all those things, those are all low flow devices. High flow devices, by definition, either meet or exceed the patient's inspiratory demand. Inspiratory demand is calculated by minute ventilation times 3 as a general rule, because no one's going to be measuring the amount of airflow, oxygen flow, going in and out of a patient. That just doesn't happen. But if you know how fast they're breathing, say 20, and you know roughly their tidal volume, based on their height, say 500, that'll give you a minute ventilation of 10 liters per minute. 10 times 3 for your minute ventilation times 3, that'll give you 10 times 3, which is 30. So for a patient breathing a tidal volume, that's the amount of air going in and out of the lungs with each breath. So say 500, that's in mLs. So 500 mLs, which is pretty standard for a normal size adult. And say they're breathing at a rate of 20 times a minute, then their minute ventilation will be 10 liters per minute, and their estimated inspiratory demand, 30 liters of gas going in and out of the lungs each minute. Seems like a lot, actually. Um, but that is how inspiratory demand is calculated. The flow rate that you set on these devices are typically way less than that. So nasal cannula up to 6 liters, simple mask 5 to 10 liters, partial rebreather, non-rebreather. Even if you increase that flow meter to 15 or greater, um, you're still not going to hit 30. And even if you do, you're not going to be able to measure it from the flow meter to know if you're above 30. So non-rebreather, even though you're cranking that thing up, even a bag valve mask device, so an ambu bag, that's not by definition a high flow device. High flow devices, it looks like it cut off a little bit there. High flow devices are a Venturi mask, high flow nasal cannula, and then your positive pressure devices, so CPAP, BiPAP, and a ventilator. Um, a few things to note. When we talk about oxygen, it's very important to know the differences between all of these acronyms. So understanding the atmospheric air, for one, is important. 78% nitrogen, 21% oxygen, and then less than 1% of a bunch of random gases. So I'm always like flummoxed, that's a good word, um, by asking nursing students this. Like, what percentage of the ambient room air that we breathe is oxygen? I hear things from like 40%, 60%. It's like, oh, OMG. No, 21%. So room air, 21%. FiO2, that is the fraction of inspired oxygen. So that's a percentage. And so 21% or 0.21 is room air. And then any oxygen, supplemental oxygen that we deliver will have a either set or an estimated FiO2 above 21. PaO2, that's a small a, that's the partial pressure of arterial oxygen in the blood, and that is derived from an arterial blood gas. P big AO2, that's the alveolar oxygen or alveolar gas equation. That takes everything into account from barometric pressure and the patient's PaCO2, carbon dioxide in the blood. That I don't know. I'll check with Dan to see if you need to know more about that because as the in transport, especially for flight, as you increase altitude, it really affects your alveoli's ability to oxygenate. So I'll get back with you on whether or not I need to go further into that equation. And then the SpO2, that's the one that you're all used to. That's the saturation of peripheral oxygen in the blood. That is your pulse ox read out as a percentage. One thing I harp on a lot is the relationship between the PaO2 and the SpO2 because if you have a general like understanding of the relationship, then you'll be able to figure out what one is if you know the other without going and actually getting that value. So, for example, look down here at the bottom of the left table. So a PaO2 of 60 roughly equates to an SpO2 of, this says 91, let's call it 90 to make it easier. So a PaO2 of 60 will give you a SAT of 90 in general. So if you have a patient who is SATing 85, then you know their PaO2 is under 60, probably in the 50s somewhere, and vice versa. Low flow devices deliver less total flow over a minute than a patient's inspiratory demand. High flow devices deliver either equal to or more total flow than a patient's inspiratory demand. Just a quick recap on nasal cannula flow for the low flow nasal cannula. So 1 liter per minute generally correlates to an FiO2 of 24 or 25% ish. All the way up to 6 liters, which correlates to roughly 44%. Understand that the FiO2, so the oxygen percentage delivered with the nasal cannula at at any given flow rate, is variable and not fixed. It depends on a number of different factors, including how quickly the patient is breathing, how hard the patient is breathing, because with the nasal cannula, the low flow, those are just the prongs, of course, that sit in the nares. And if we're at a flow of 1, 2, 3, 4, 5, or 6, that's the total flow in liters per minute that the cannula is putting into the patient's body. We know that inspiratory demand is, in the example I used a little bit ago, it was 30 with a rate of 20 and a tidal volume of 500. So 30 is way higher than 1 through 6. So that patient will be entraining air, room air, 21% room air, around those prongs that are in the nose. So if the patient increases the amount of oxygen air per breath, that they're entraining more air around those prongs. So the actual oxygen percentage that is being delivered to the patient's lower airway is lower in that case than this chart that you've probably memorized. So keep that in mind when you're looking at, like, oh, they're on 30%, they're on a 2 liter cannula, so it's like 28%. Okay, it's probably around 28%, but how are they breathing? Are they slow and shallow breathing? If that's the case, then that FiO2 is probably higher than 28 because not as much air is being entrained around the nasal cannula prongs. And if they're breathing hard and fast, they're doing their tachypnic, their asthma exacerbation, or DKA or Kussmaul's or whatever the case. Well, they're entraining a lot more air around those nasal cannula prongs, so the actual delivered oxygen percentage is going to be lower. Um, Note that anytime you pipe O2 from the wall or from a tank, the amount of oxygen is pure, so 100%. So it's up to us to dilute it, and we do that by all of the devices that we have. I won't spend a lot of time on these devices, but it's good to know some general things about them. So a low flow nasal cannula, O2 range, 22 to 40, 45%, somewhere in that neighborhood, depending on the factors I just talked about. Flow rates usually go up only to 6 liters per minute. And then I'm not going to go through all of the stuff that I would in RCP 100, but in terms of who to use it for, etc., go ahead and take a look at that. For simple masks, I assume that you'll probably have those on the rig. We don't use those very often in the hospital. A lot of times, like say you're picking a patient up from a primary care facility, and they didn't have all the fancy masks that we do in the hospital, so they're on a simple mask. Well, what the heck does that mean? Well, simple mask uses a reservoir system. Usually you set the flow to somewhere between 5 and 10. You get like a marginal FiO2 range, like usually up to around 35%. It's quick, it's easy to use, it's disposable, single patient use, but it is variable in terms of the FiO2 delivered, and it is not in any way a high flow device. So non-rebreather and partial rebreathers. So a partial rebreather here, sometimes they've got the reservoir bag attached to it, but when you have a 3-in-1 mask, if you remove all 3 of the flaps, then it becomes a partial rebreather. So that is O2 range like 40 to 70. 70 seems awfully high. It's probably like 40 to 60% depending. Usually you do a minimum of 10 liters per minute for the flow, or just kind of crank it to 15, or even flush the flow meter if you have a Thorpe tube. That's okay. I steer clear from teaching about simple masks, but you'll probably see them more in the field than any RT would in a hospital. So important to have just a general idea of them. For non-rebreather masks, like you see here, so that does have the reservoir bag. For a flow setting, we put it at a minimum of 10. I teach 15 or flush. I mean, just crank it. In order for it to work appropriately, that reservoir bag needs to stay inflated at least half or 2/3 at all times. So especially on end exhalation, you want to make sure that that bag does not collapse. If the bag collapses, then you need to turn up the flow. And that is the same with a bag valve mask as well, or an ambu bag. The FiO2 range for a non-rebreather is 60 to 80%. How many of you raise your hand? Oh, non-rebreather, 100%. You'll hear that all the time in the ER. You'll hear it from from doctors, from nurses. Put them on a non-rebreather, 100%. Non-rebreather mask does not deliver 100% oxygen. The only way that it could is if the patient is not breathing on their own, if they're apneic, and you just like strap that to their face and flush it out. But turn the flow all the way up. But if they're apneic, then a non-rebreather is not going to do them any good because they need manual ventilation. Venturi masks, those are the first in the classified oxygen devices that are high flow. The reason that Venturi masks are high flow is because of the mechanism in these little plastic pieces. Those entrain air, but these little adapters here, they create what's called the Bernoulli effect uh, with regard to like directional flow, and um, so the total flow of the device for a Venturi mask is never the flow that is set on the flow meter. Instead, there's an equation that we use based on the air-oxygen ratio to determine the device's total flow. Now, I don't think that's anything that you'll ever need to do in the field, but it's super important to understand if you ever use a Veni mask, um, always, always, always go by what information is on the adapter. So each adapter will um, will have a FiO2 and a flow to set it at. And it's extremely important that you always set the flow as it says on the adapter for it to achieve the FiO2 that the adapter says. One of the biggest misnomers, we see it all the time in hospitals with patients on a Veni mask, they're desatting, so the nurse turns the flow up. If you turn the flow up on a patient who's wearing a Venturi system, that will not affect the FiO2 delivered. So it is not the same as like a nasal cannula. And a lot of times it can make it can go the other way. So instead, if you have a patient, let's pretend this green one is a 28% adapter. So they're getting 28% FiO2, and that is fixed because of the fact that the Bernoulli principle with these adapters increases increases the flow, the total flow delivered. Um, the patient is typically gets exactly the FiO2 that's on these adapters. So if this green one was 28%, but their SAT was 87%, we need a little more oxygen. We'll go check the adapters, go up to the next one, which would be 31%. I think that one's usually blue, but they're different based on different manufacturers. And switch out the entire adapter to adjust the FiO2. And then make sure that you have the flow setting set to whatever that new adapter says. So here's just an example of the different types of adapter colors. What makes these different are the size of the holes. Those are the air entrainment ports. So if you have a larger hole, then more air is getting through. So your lower FiO2 adapters, so 24% for your blue, if you were looking at it in real life when you set it up, these holes are a lot bigger than, say, your orange, which is 50%, because that does not entrain as much air. And as a result, the flow that is set, and you can't see on these, but if maybe in lab we'll get these out. The flow for the higher percentage FiO2s is typically higher because you need to overcome the change in resistance with the air entrainment with these adapter pieces. But that's probably more than you need to know. Know that to change the oxygen on a Venturi mask, you switch out the adapter. You don't change the flow. All right, let's move on to heated high flow nasal cannula, or heated if you can. Let's see. All right, that's good for now. What does a high flow nasal cannula do? So, high flow nasal cannulas primarily do three things. First, they deliver high flow rates that can match or exceed a patient's inspiratory demand, like we talked about, which reduces the amount of room air that's entrained and delivers a more accurate FiO2 reading. So, if adult patient's on a high flow of 60, so 60 liters per minute, that is their inspiratory, the inspiratory flow given by the high flow nasal cannula device, and that's going to be greater than um, their their personal inspiratory demand. So in that regard, the actual flow rate for a high flow nasal cannula does make it a high flow device. Um, Second, uh, now typically they deliver warm and humidified gas, which improves comfort and helps to maintain mucociliary function, like we talked about in one of the previous lectures. Um, Not all high flow systems have a heated humidification with it, especially on in the field on transports. So one thing you may see, and this is kind of a little segue, you may see the Salter high flows. Salter being a brand. They're green. They look like just a big old like large bore nasal cannula that you turn the flow up a little bit higher, so you can go to like 10 to 15 on the flow. Um, do not mistake those for being true high flow devices because they, in most cases, are not. But they're just a little better than a nasal cannula, a low flow nasal cannula, for people who need a little more oxygen. Those came out during COVID when high flows were scarce, and they do serve a purpose, but they are not true high flow nasal cannula devices because in order to be a true high flow nasal cannula device, you have to be able to go up to either 40, 50, 60, 70 liters a minute. You have to have a heated humidification system with it, and then you have to have a way to dial in the FiO2, so an oxygen blender. And unless you have one on the rig, you're not going to be able to know what FiO2 a patient is getting with one of those Salter high flows. As far as like the physiology of high flow nasal cannula, the biggest thing it does is they wash out dead space in the upper airway, so in the nasal cavity, the nasopharynx, things like that. That can help to reduce a patient's CO2 and their CO2 rebreathing, and help to slightly decrease their work of breathing as well. But it's not a it's not a great thing for like somebody with a ventilation issue. High flow in general is for people who need a fixed oxygen concentration, or if you know that you need to know the FiO2 that they're actually getting, and for folks who have increased work of breathing. Um, in the pediatric population, so bronchiolitis, RSV, pneumonia, any viral illness is going to cause a PEDS patient to present pretty similar. They're going to be tachypnic. They're going to be maybe a little grunty, retractions. They'll have some snot in their nose. They might desat if the O2 is compromised as a result of those things. It could have a fever. But either way, they're going to be tachypnic and have some retractions. So some increased work of breathing. What high flow technology does is because it either meets or exceeds the patient's inspiratory demand, it takes the work from the work of breathing off of the patient, at least a little bit. So in the peds population, especially your bronchiolitis RSV kids, they benefit greatly from high flow nasal cannula therapy, and you don't have to go too high on the flow. I mean, up to 20. They benefit greatly from that because it helps to reduce their work of breathing by taking some of that pressure off of literal pressure off of them having to maintain that breathing rhythm. Okay. High flow nasal cannula therapy is not for everyone. It really shines in like slight hypoxemic respiratory failure when standard oxygen devices aren't enough. But the patient still needs to be protecting their airway. They still need to be cooperative with it. They need to be breathing on their own, and things like that. It's helpful for patients with increased work of breathing who can't get adequate support from a low flow device, any of them, or who may not tolerate like a BiPAP mask. It's also useful when comfort and communication matter. So somebody with pneumonia or interstitial lung disease who are uncomfortable with masks, high flow can be a great option for them. Um, so the ideal high flow nasal cannula patient is hypoxemic, so they need supplemental oxygen. They're working hard to breathe, but they're still awake enough and alert enough to be able to manage their breathing on their own and their secretions to a degree. Transport considerations for oxygen for high flow, um, a lot of them. So high flow adds some logistics to the whole patient treatment process when you're transporting a patient. First off, it uses a lot of oxygen. So you've got to calculate whether your cylinders or your onboard supply can support that that amount for the flow, the FiO2, and the trip length. So understanding the tank equations is super important. If you need a refresher on that, or if you're not aware of that, shoot me a message in Canvas, and I can put something out for those. Other considerations, so making sure the cannula itself, the high flow nasal cannula itself, is secure and the tubing is secure enough to prevent it from moving around during the run. Third, always monitor their work of breathing, respiratory rate, SpO2, and mental status. The high flow should improve those things. So if those get worse, then high flow may not be enough for that patient. And it's not. It doesn't just like make the numbers look better on the monitor. You should actually see you know some form of improvement with the patient themselves. And then finally, have a clear backup plan to escalate to either non-invasive ventilation or intubation if they fail or don't tolerate, or if the high flow nasal cannula itself does not seem to be doing the trick. So let's take those things and compare it with our patient assessment and determine some signs of high flow nasal cannula failure. So anything, I mean, and this is all kind of common sense. So worsening tachypnea, worsening respiratory distress, persistent or worsening hypoxemia, especially on high FiO2s. If the patient gets more fatigued or agitated or confused, or if they simply can't tolerate having something in their nose. Um, what you should do in these cases, so reassess the position of the prongs, make sure the device is working properly, increase the support if if necessary, and then know when to either escalate or de-escalate care. Section 3 is non-invasive ventilation, so CPAP and BiPAP. Before I get to that, though, I want to clarify with high flow nasal cannula. So you may hear in the field, especially from residents and things like that, that high flow nasal cannula provides PEEP. And while it does, it is not what you should use if you need to like be able to monitor the patient's actual PEEP. So there's a ton of studies over the last 15 years about high flow therapy and PEEP. And the latest that I read, the conclusion is that for every 10 or so, you know, liters of flow on a high flow, then the PEEP delivered is one. So if you and I have a intrinsic PEEP of like 3 or 4, we put a patient on a high flow nasal cannula of 60 liters per minute, you might get like 4 or 5 for PEEP, but that's not something that you can monitor, not something that you can measure. So if you need to add PEEP because of things like oh, if they're acidotic, if you get a blood gas and they're compromised with their ventilation, or if they're CHF and they've got a lot of you know fluid on the lungs or pulmonary edema, anything that needs positive pressure, high flow nasal cannula is not considered a direct positive pressure device. While it can um, while it can give some PEEP, it should not be used to deliver PEEP. It's more like it's an added benefit because it gives a little bit of PEEP. We just don't know how much, so you know, don't think of it in those terms. And for ventilation, so if you get a blood gas back and it's 730 and 50, and we want to increase ventilation because they're under ventilated, the high flow interface itself is not good for correcting acid base imbalances. Can it have a small effect? Sure. Is it does it have a measurable effect? No. So non-invasive ventilation, I in my RCP 131 class, I spent about a month going over it, and here I've got a few minutes. So let's blow through it, and I'm happy to answer questions if you have them afterward. So the goals of non-invasive ventilation. So non-invasive ventilation includes CPAP and BiPAP. So CPAP is continuous positive airway pressure. BiPAP is bi-level or 2 levels of positive airway pressure. The goals are to recruit alveoli to improve oxygenation and to reduce or prevent airway collapse or atelectasis, to reduce work of breathing, and in most cases to avoid intubation. Non-invasive ventilation is great for helping patients in respiratory distress who have oxygenation issues as well as ventilation issues. The key takeaway for the two different types of NIV, CPAP versus BiPAP, is that CPAP is a continuous single pressure. CPAP equals PEEP equals EPAP, or expiratory positive airway pressure. Depending on the device that you are running non-invasive ventilation through, you'll have different settings to manipulate. Next week when we get into vents, I'll show you the Hamilton interface because a lot of rigs have the Hamilton T1 or C1, and I'll show you how CPAP and BiPAP look on that. But CPAP, just positive pressure, holds the airways open throughout the duration of the breathing cycle, so inspiratory and expiratory phases. Um, the PEEP itself, or the CPAP, those are all the same. CPAP, EPAP, PEEP, all the same. That is the amount of pressure that is exerted on the lungs around the alveoli at end expiration. So it holds those lungs open, measured in centimeters of water pressure, and that helps in a couple of ways. So CPAP in general helps to improve oxygenation because it gives the alveoli more surface area to be able to exchange, oxygen and carbon dioxide, and it also helps to push fluid off of the lungs in the case of edema or CHF. So CPAP is typically used for oxygenation and for, say, obstructive sleep apnea, so people with airway obstruction when they sleep. BiPAP, on the other hand, by having those two pressures, BiPAP, we've got your EPAP, CPAP, PEEP as the bottom number, but the top number is the pressure above your PEEP, that when a breath is delivered or triggered by a patient, it'll go up to a top pressure or a peak inspiratory pressure, and that is the top pressure setting on a BiPAP. So IPAP over EPAP. Because of the two pressures, the difference between the two, IPAP minus EPAP, that is your pressure support, and pressure support is what we use to change the ventilation of a patient. So as far as blood gases go, pH, PaCO2, those are the key determinants of ventilation. And when a patient is on BiPAP, we adjust the difference between the two pressures to either provide more ventilation, more support, or less ventilation, less support, to help correct the ABG and get it back into normal range. And we'll do that a bunch going forward. So just to keep things kind of tidy, when is CPAP most commonly useful? Well, pulmonary edema with hypoxemia, increased work of breathing, selected acute hypoxemic states when the patient is awake, cooperative, and protecting the airway. Very important. They need to be able to remove the mask when they're on CPAP or BiPAP. Now that may not come into like as much play when you're en route because you're always there with the patient, but still, if they're if they're obtunded, if they're somnolent, then tube them. If they need to be awake and alert to be on CPAP or BiPAP. CPAP for fluid, so CPAP for CHF, CPAP for pulmonary edema. BiPAP, on the other hand, that's typically reserved for patients with COPD exacerbations, or if they're hypercapnic or have high PaCO2s, increased work of breathing, but also for patients who need both oxygen and ventilation support. And selected mixed respiratory failure states when the patient remains cooperative and monitorable. Sure, but mainly, mainly it's for your COPD patients and pneumonia patients, people who have both oxygen and ventilation compromises. I've got a few slides from our RCP 131 course from going over non-invasive ventilation. This guy here is a Philips Respironics V60. It's an in-hospital unit, but it functions the same as any other non-invasive ventilator. So here are indications for NIV in general. So hypercapnic respiratory failure, COPD or CHF exacerbation, sometimes asthma, facilitation of extubation, mainly for COPD patients. You shouldn't get into that in the transport world. Acute cardiogenic pulmonary edema for sure. End of life care. So if you pick somebody up and they're a modified code, do not intubate, stuff like that. Well, you can throw them on a BiPAP for comfort measures. And then post-op or post-extubation respiratory failure, just to help those folks kind of get over the hump. Chronic non-invasive ventilation use, usually for so nocturnal hypoventilation, that would be like your obstructive sleep apnea patients, and those are far less common. Goals of non-invasive ventilation: improve gas exchange, especially in BiPAP, avoid intubation when necessary, decrease mortality, decrease the ventilator length of time, decrease hospital length of stay, decrease VAP, that's ventilator associated or acquired pneumonia, relieve symptoms of respiratory distress, improve patient vent synchrony, maximize patient comfort. Those are all just kind of generic things. And same with the chronic ones. If you're fortunate and you're working off of blood gas, but prior to initiating non-invasive ventilation, these are the criteria that we teach. So usually, if somebody's got, basically, if they're in respiratory acidosis, so pH below 735, PaCO2 above 45, and then a PaO2 FiO2 ratio of less than 200, you shouldn't have to worry about that, especially in the field. But yeah, if they're acidotic, think BiPAP, think NIV. As far as assessment goes, if they're using accessory muscles, if they're paradoxically breathing, if they're tachypnic with a rate of greater than 25, if they've got moderate to severe dyspnea or shortness of breath, beyond baseline for those patients who are chronic, then think non-invasive ventilation. Exclusion criteria for NIV. So when should you not use it? Well, if the patient's apneic, tube them. Inability to protect their airway, protect it for them, not with a mask. Insert something. High aspiration risk, not a good idea. Any kind of hemodynamic or cardiac instability, you really need to be careful about BiPAP, especially with the different pressure settings, so that they're not too high. Lack of patient cooperation. If they won't wear a mask, can't force them. Inability to use the interface. So if they have any facial fractures, burns, trauma, anything like that, you're not going to strap a mask on them. Copious secretions, because BiPAP or NIV in general does not help with secretion, either production or removal. And then inability to remove the mask, again, that's more for in hospital when people aren't watching them 24/7. Predictors of NIV success: minimal leak, of course, low severity of illness, obviously. So a reasonable respiratory acidosis, they're really good at correcting. And you should see improvement in gas exchange on the blood gas results within 1 to 2 hours of initiation. So, so if you go to pick up a patient and they're already on BiPAP, take a look at the gas that they got, what the last gas was, and have in the back of your mind, okay, is it better than the previous one? Is it worse than the previous one? What changes did they make on it? in between the two blood gas draws? Are you comfortable transporting the patient on the settings that you found them on, based on the last blood gas that was resulted? So a lot of things to kind of keep in mind. Some of the not so nice things that non-invasive ventilation can cause. Um, as far as the interface goes, discomfort. Um, Lots of times we get breakdown around the bridge of the nose or around the nares. Um, Definitely claustrophobic for patients. Pressure ulcers for sure. Skin rashes, uncommon, but it does happen. If it's not heated and or humidified, then they're likely to get more congested and dry. Some sinus and ear pain, and this last one here, gastric distension. So when a patient's on non-invasive ventilation and there's a mask interface that's providing the flow and the pressure, um, it's not a tube in the trachea. It's not an eye gel that covers up the esophagus so that everything goes straight into the trachea. It's just a mask on the face. So all that air, all that oxygen, all that pressure, all that flow, that's going just into the upper, airway. And so some of it goes down, the one tube into the lungs. Some of it goes down the other tube into the stomach. And so a big thing that we look out for anybody who's on CPAP or BiPAP is their abdomen, making sure that it is not distended or hard or whatever the case. Contradictions and causes or cautions, I'm sorry, for non-invasive ventilation. Inability for the patient to protect their airway. If they're puking, don't put it on. If they're at an aspiration risk, don't put it on. Severe facial trauma, severe agitation, if they're not going to tolerate it, I mean, use your magic, give them some meds, or find a different way to ventilate them. Severe hemodynamic instability or immediate need for intubation. Obviously, do what the patient needs. If they don't tolerate the mask or cooperate, or if they can't clear their own secretions, probably not the best thing to put on them. And yeah, delayed escalation when NIV is failing can definitely worsen the outcomes, especially in the short term. In terms of monitoring non-invasive ventilation during transport, you'll have a few things you can look at, things at your disposal. So SpO2 from the pulse ox, trending their oxygen response, and knowing that their oxygenation is directly related to the FiO2 that is being delivered, as well as the PEEP, so that EPAP level. Um, the end-tidal CO2 and ABG, and that will be for another lecture. That's way too much for this one. Work of breathing, of course, just patient assessment. Look, listen, and feel to decide whether or not it's actually helping, and then their mental status change. Watch for any kind of fatigue or CO2 narcosis, which would be, I mean, they would pretty much become obtunded at that point. Suctioning. Before we get into suctioning, let me go back quick for non-invasive ventilation. So, and I'll give you there's a sheet that's in Canvas. Take a look at that. It's my little 2 or 3 page like cheat sheet for all things non-invasive ventilation. But take a look at that for like normal settings. Typically, the IPAP or the top number is like 10 to 20. Typically, your EPAP is 5 to 10, so it's 10 to 20 over 5 to 10. Eye time, usually 1 second. Um, we want a shorter eye time for COPD patients so they have a longer time to exhale. A longer eye time, so longer than 1 second for people with restrictive issues, so any kind of fibrosis or ARDS, impending ARDS, things of that nature. The rate that is set for the non-invasive ventilator, so when they're on BiPAP and you set a rate, that is a backup rate. We expect them to be able to breathe at a rate on their own, and that only kicks in when they fall below the setting on the vent, and we'll get into that down the road. Suctioning en route, very important. Man, I remember neonatal transports, some peds transports where, I mean, the secretions were just everywhere, and we spent the whole time just trying to manage their secretions, and couldn't really do anything else, like with their ventilation or with their, oxygenation, because we were just, spending all effort on just keeping the airway clean. Um, when you do that, other things kind of follow suit. So suctioning clears secretions, blood, vomit, mucus, plugs, anything that obstructs gas flow or threatens aspiration. Improves airway patency and may improve ventilation and oxygenation when there's an obstruction present. So clear the secretions and other things will improve. Supports both non-intubated and intubated patients. So suctioning, whether it's a booger be gone or a nasal aspirator or a yonker, or if they're intubated, inline suction. I mean, use what you have and know how to use it. Know the suction pressures. So suction pressures for adults are typically negative 120 to negative 150. And then peds is 80 to 100, and neo is 60 to 80. And I say that with the squinty face because those change all the time depending on the source that you use. Excessive suctioning, however, can cause all kinds of issues. Can cause trauma, can cause bradycardia, hypoxemia, de-recruitment, but it can also make secretion production worse. So the more you suction, the more you irritate the airway, and the more irritated the airway becomes, the more secretions the airway produces. So you got to be careful not to oversuction. Trends in the last, 5 to 10 years, we never routinely suction anybody, and we only suction as little as necessary to help the patient in that moment. So when you go to suction, there are definitely principles for safe suctioning. Um, Only suction as needed. Always use the appropriately sized catheter. Um, there are a couple different schools of thought on that. But typically it's like well, I'm going to get into this more when we do vents, because inline suctioning is far different from not. Let's see, pre-oxygenate, always pre-oxygenate at 100% before suctioning, and then always limit. So limit the duration that you're down there, no more than 15 seconds. Limit the attempts or the number of times that you pass a suction catheter. Um, and always reassess the patient before suctioning again. Don't just, oh, I'm going to suction, 6 times. Nope. Suction once, reassess, and then only suction again if necessary. And then always watch out patient assessment wise for any kind of bradycardia, if they desat, if you notice any trauma, like if you end up suctioning a bunch of blood, did you hit something, worsening distress, and um, and things like that. When you do suction, always be aware for certain things, contamination. Um, Watch for mucus plugging. Watch for DSATs. Watch for loss of PEEP, especially in patients who are on non-invasive ventilation, and airway trauma, bleeding, etc. A couple of things to note for kids when you suction them. Pediatric airways are smaller, so even modest looking secretions can create a significant obstruction. So even though you don't get much out, it could make a big difference. So keep that in mind. Kids desaturate more quickly because they have less reserve and a higher metabolic demand. Always use age-appropriate catheter size and a gentle technique. Don't just jam the catheters up their noses. And then any visible distress, retractions, coarseness, secretions, poor air movement, those all can indicate the need for suctioning. And all of the things from the that last slide, those are applied to neonates, um, just in with more urgency based on their size. So when should you suction? To suction or not to suction? Um, if you if anything is visible, an obstruction, secretions, then yes, suction. If there's a concern for mucus plugging based on auscultation, based on oxygen desaturation, based on patient presentation, yeah, suction them. Are you going to get the mucus plug out? Maybe, maybe not, but you could still help. If there are no secretions on a stable patient, don't do it. If they've got severe hypoxemic lung disease, so a bad COPD patient, yeah, suction them if they need it, but make sure that you plan and pre-oxygenate so that you don't risk them crashing as a result. Um, Suctioning can create a vagal response as well if you go too far and hit that. So be prepared for those things as well. Always keep in mind the devices that you have at your disposal and kind of where they fall in the continuum or the pathway of escalation with regards to patient condition. So, room air, no support, low flow nasal cannula, simple mask, partial rebreather, non-rebreather, venti mask can be thrown in there. Then you escalate to high flow nasal cannula. Then the next step from there is CPAP, and then BiPAP, and then intubation. Let's do a quick example. So which strategy fits best? So our scenario is we've got a 68-year-old with acute cardiogenic pulmonary edema. Okay, so I'm thinking fluid on the lungs, fluid backup, fluid buildup, probably some pedal edema to go along with it. All right, it's acute fluid. So I'm immediately thinking positive pressure. So I'm ruling out all low flow devices. I'm ruling out high flow nasal cannula because that is not most appropriate for fluid. So we want positive pressure, so positive airway pressure or PAP, to push off the fluid to allow for better ventilation and oxygenation. So because they have acute cardiogenic pulmonary edema, they are anxious, they are tachypnic, they are working and using accessory muscles. They've got persistent hypoxemia because they can't oxygenate because there's fluid, impeding everything. And they're on a high concentration mask oxygen. So on a breather. The patient's awake, that's good. They're following commands, that's good. And they're coughing up pink frothy sputum, which you would expect in acute cardiogenic pulmonary edema. So what are the major oxygenation problems here? Well, one, we've got a patient who's not breathing well. They're anxious, they're tachypnic, they're retracting, they're desatting. But they also are their lungs are so fluid filled that the oxygenation can't occur, the gas exchange can't occur, the oxygen delivery to the blood to take it to the tissues can't occur because all of the fluid that is impeding that process. So would high flow CPAP or BiPAP be the next step? And how does secretion management fit into the plan? Well, if they're coughing up pink frothy sputum, you may or may not need to suction them. If they have a productive cough, then you don't necessarily have to suction, unless they're acting as though they, can't cough up enough. Then sure. But in terms of what device to use, well, we kind of need more information, but we can at least know where to start. So I would start with CPAP because of the pulmonary edema. And then I would, the what the CPAP will do by creating continuous positive airway pressure is it holds the distal lung fields open to and indirectly pushes off fluid that's accumulating in between. Okay. Um, as that happens, as the fluid goes off the lungs, as the lungs inflate or expand better as a result of the CPAP PEEP, um, gas exchange should improve, work of breathing should improve, um, everything should kind of improve. What if it doesn't? We don't have a blood gas to be able to compare anything. So you would still likely want to get a blood gas, and then you can determine what to do based on that blood gas. If the blood gas comes back and they have a ventilation issue along with it, so low pH, high CO2, well, then you might need to switch to BiPAP because BiPAP helps with ventilation, whereas CPAP only helps with oxygenation and pushing off fluid from the lungs. Key takeaways. So, I mean, each one of these topics, they're lengthy lectures. My goal for this was to give you maybe a little more information than you've already had, and to help kind of put things together so they make sense, so that when you're taking care of a patient uh, on a critical care run, then you're a little more prepared. So oxygenation and transport depends on a lot more than just FiO2. Airway patency, airway recruitment, alveolar recruitment, VQ, so ventilation perfusion matching and or mismatching, um, hemodynamics like hemoglobin, perfusion, all of those things matter with oxygenating a patient. High flow nasal cannula can improve comfort. It can meet or exceed a patient's inspiratory demand, and it can support selected hypoxemic patients, but a lot of things need to be taken into consideration, like whether it's a fluid issue, whether it's a ventilation issue. Um, but for high O2 needs and increased work of breathing, high flow is a good place to start. CPAP mainly supports oxygenation and alveolar recruitment. while BiPAP adds that ventilatory assistance from the pressure support that is given when you set both the IPAP and the EPAP. And then suctioning is a critical airway skill across all age groups and should be performed only when indicated with age-appropriate technique and with caution. And we'll probably do those things in lab, I would think. Whew, that's a long one. Thank you.